Hello, everybody. My name is Tzu-Fei Wang. I'm a adult hematologist and associate professor in the Division of Hematology here at the Ottawa Hospital, University of Ottawa, in Ottawa, Canada. Today, I'm very excited that we have the roundtable discussion and with Dr. Wolfgang Winkelmayer, who is a nephrologist who has been doing a lot of great work in this field to talk about the use of this exciting new molecule, factor 1111A inhibitor for patients with advanced renal disease. So I'll let Dr. Winkelmeyer to introduce himself and we'll get started.
I'm Wolfgang Winkelmayer. I'm the Chief of Nephrology and the Gordon A. Kane Chair in Nephrology here at Baylor College of Medicine in Houston, Texas. And I'm excited about this roundtable discussion today about some very, very interesting innovation in the anticoagulation space.
So we'll go ahead and get started. What do you think? First of all, Dr. Hunkemeyer, what are the unmet needs of nephrology patients in regards of anticoagulant use?
The biggest unmet need as it relates to advanced kidney disease patients and anticoagulation is a solid evidence base. And that lack of evidence is half a century old, and it dates back all the way to when warfarin came to market. As unfortunately is common, patients with advanced chronic kidney disease or those with kidney failure on dialysis were systematically excluded from all those trials. And as we all know, of course, those trials led to top-level evidence recommendations for anticoagulation specific indications, most prominently for stroke prevention in atrial fibrillation, where the risk benefit relationship was highly favorable. Now, one has to ask oneself, why wouldn't the general evidence pertain to patients with advanced kidney disease? And the key answer here is that these patients are not only at highly elevated risk of thromboembolic events, but they are also very prone to bleeding. And people are very risk averse, including clinicians. And as a result of it, despite very, very strong evidence in the general population, very, very few patients, for example, on dialysis who developed and were first diagnosed with atrial fibrillation actually received warfarin. Maybe 20% of suitable patients were started on oral anticoagulation with warfarin. Now, then, of course, the next chapter came with the DOACs, but it repeated the previous story. Again, all those pivotal trials that brought these, direct thrombin inhibitor, dabigatran or the three, anti-10, factor 10 inhibitors, did come to market again while excluding patients with advanced chronic kidney disease from their pivotal trials. And so there was very, very little support for use of this, but the FDA at some point decided that they were willing to give a dose recommendation for apixaban specifically in patients on hemodialysis. And what we know now from historic data is since approximately 2014, the use and initiation of apixaban following a first diagnosis of atrial fibrillation in patients on hemodialysis really went up, and at this point probably a third, maybe 40% of patients newly diagnosed with atrial fibrillation actually are initiated on apixaban. Two major throwbacks here. With regard to warfarin, we know from observation studies that these patients on dialysis actually are difficult to control in the TTR range. And actually spent the majority of the time outside the therapeutic range, which defies the intent of a secondary prevention or primary prevention drug. And then secondly, we know that persistence with initiated oral anticoagulation is very poor. Most patients take their warfarin and the same with the DOACs for like a month, maybe 2 months, and that's it. And so if you're outside the therapeutic range or if you're not able to persist with an indicated anticoagulation regimen, you cannot expect any benefits from such an approach. And that's what the major evidence gap is that we experience today.
Yeah, thank you. This is great. Yeah, I would say that as a hematologist and thrombosis kind of specialist here, it's also quite challenging for this population of patient with advanced kidney disease. They are often referred to us when they either have we see most patients actually not atrophy patient people with acute VTE where you don't really have a lot of options for not in starting in a coagulation, as on unlike the AFib population that which you mentioned that a lot of patients are arguably undertreated. But for VT, we have to start them on it. But these population are known to have such a high risk of bleeding and thrombosis, and there's often a lot of discussion, what can be done, and a lot of patient. And also in Canada, we actually do not have the package approval, and I believe it's in European countries as well as in FDA to actually still to use a pixaban for especially for patient with creatinine clearance under 15 or on dialysis. So I would say that my experience from talking to my colleague, most of my colleagues are still feeling quite uncomfortable using a pixaban, despite, I do know that we have quite some observational data, particularly in small randomized control trial data for dialysis patient on pixaban. So a lot of times we even have to admit these patients, whether it's right or wrong, to the hospital because again we're dealing with acute venous thromboembolism, so we can't really just start warfarin. So if we want to do warfarin, we have to admit to hospital for heparin and bridge to warfarin. And as you have already beautifully alluded to, neither options, heparin drip or warfarin, are really ideal because people spend the majority of the time outside the range, and it just creates even increased risk of bleeding and clotting. I think you have already, addressed to this about most randomized control trial certainly exclude patient with limited kidney function. Are there any other limitations that you would like to add for previous clinical trial examine anticoagulant therapy in this population?
Yeah, no, I mean, we were lucky enough at some point to actually do some randomized control trials. There was the Exadia AFNet trial in Germany and the Renal AF trial in the United States that randomized patients to either vitamin K antagonist or to apixaban. And what we learned in rolling out these trials that we could not possibly recruit. Our colleagues were very reluctant to enroll patients in these trials. It may have something to do with nephrologists not being very interested in controlling INR and prescribing warfarin on an ongoing basis. There was not a central lab that would provide, or a central service that would provide warfarin prescription. But these were very, very small trials that really didn't advance us very much. And as a result of it, the community has been quite excited to see that there is an innovative new class of drugs coming our way.
Great. So that's a great leeway to go into. So going to our discussion of factor 1111 inhibitor, how do you think these will address this unmet needs and to change the therapeutic landscape? And if you can also discuss some available data showing the efficacy and safety of these drugs in the advanced kidney disease population.
Yeah, absolutely. Just the biology and the therapeutic angle of factor 11 or factor 11A inhibitors is genius. To use, the natural experiment, if you will, or the natural model of hemophilia C, which is a bad name because it's not a hemophilia. Patients who have this, genetic defect don't really bleed, but they also don't experience any or very, very few thromboembolic events. And so taking this into the drug development, process and then coming up with molecules that would inhibit factor 11 or factor 11A or both is really an outstanding concept. And we're, of course, aware of the large phase 2 trials that have already been published in different indications in the more general population, secondary stroke prevention, atrial fibrillation, stroke after atrial fibrillation, post-MI, etc. And some of those have now gone into phase 3 trials even. We have a very, very interesting situation and very pleasant experience in that some of those trials were actually conducted, and some trials were specifically conducted in patients with kidney failure on dialysis. And that's something that is wonderful and new for our community. We are usually not the center point or centerpiece of focus of innovation drug development, but here we really are, because of the potential to dissociate the thromboembolic prevention from the bleeding risk. And that's exactly what these patients need, that, as I said, are at such high risk of bleeding. If you can bring, an intervention into place that lowers thromboembolic risk while not increasing and not meaningfully increasing bleeding risk, would be a slam dunk if it can be shown in top-level trial data. And so as a result of it, 3 large phase 2b trials have been conducted. 2 are done and have been presented. A third one is ongoing and will hopefully present data in the next, 6 to 9 months, I would say. And the interesting situation here is that these are all injectable drugs. And why are injectable drugs attractive? Well, hemodialysis patients come to dialysis 3 times a week. They get all kinds of injections during that treatment. And so that limitation that an outpatient, non-dialysis population would have in self-injecting or needing to go into infusion center for injection or something like that is not a factor. These patients are already there and can receive these injections. And as a result of it, we are now very, very optimistic that there's a path forward. With regard to trials, we have had 3 phase 2b trials of different factor 11 or factor 11a inhibitors in patients on hemodialysis. That's absolutely novel to have designated trials in that population. One was using fesomersen, which is a LICA product. One was osocimab, which is a monoclonal antibody. The third one is MK-2060, also an antibody product. And the first 2 trials with fesomersen, osocimab have been published. The third one will probably report out in the next half year or 9 months. And in very, very brief summary, it was very, very clearly demonstrated that there is no excess bleeding in patients on factor 11 inhibition compared to the placebo groups. These drugs were well tolerated. And then thirdly, in terms of looking at the future endpoints of a phase 3 program, there were very, very few endpoints that were observed, perhaps reflecting also the relatively healthy nature of these patients. But most encouraging was the fact that these trials, all 3 of them, enrolled extremely quickly. And that clearly reflects the enthusiasm in the nephrology community to bring innovation to a very, very difficult conundrum in clinical nephrology therapy, and to enroll patients into these trials and get, a new innovation, a new innovative drug or drugs to market that will clearly then be a game changer, hopefully, for the treatment of these patients.
Yep. That's great. I think you actually already alluded to, but how do you think, in the future holds? Sounds like, moving to a phase 3 studies, definitely. And how can hematology and nephrology be, collaborating on this to hopefully bring the new exciting medication for this patient population in the future?
Yeah, so several phase 3 studies have been launched, of course, in the general population. Some of those have relevance to kidney disease. The Oceanic AF trial, of course, has been terminated, and it had a sister trial, Oceanic Athena, in which specifically, I think 300 dialysis patients were supposed to be enrolled. So that's unfortunate that is no longer going forward. However, the LILAC TIMI-76 trial is ongoing, and one of the 5 clinical conditions that qualify patients for participation in this randomized controlled trial is advanced kidney failure. So at least here we will have, that population represented in an ongoing phase 3 trial program, which is amazing. And then, of course, we're hoping that, the encouraging findings from the existing 2 phase 2b studies and then from the upcoming Merck trial that will report out soon, that somebody will take the money into their hands and be encouraged about the preliminary trials and really roll out a large definitive phase 3 trial in dialysis patients to provide the evidence that we can then use to bring those drugs to market and to treat those patients. as it relates to collaboration, it's a big problem, to be honest. That the field and the treatment of especially these very very complicated patients is extremely fragmented. We actually don't know who are the people who prescribe anticoagulation these days. Most of it may be in the hospital, and it may be hospitalists, it may be cardiologists, I think very rarely nephrologists, but the nephrologists are the ones who see the patients later on and need to continue these treatments, and maybe that's where the breakdown happens in terms of persistence with these regimens. And hematology very, very rarely gets involved, at least in our institutions here. So I think the collaboration among different disciplines is something that really needs to be focused on and needs to be improved. Only this way we'll be able to not only bring these people on these anticoagulant therapies, but also maintain them in a way that's beneficial in the long run.
So thank you very much, Dr. Winkelmayer. This is a great discussion and really help us to understand this field better. So thank you, everybody, for listening, and we hope this is quite educational, and we will talk soon.
Thank you so much for the opportunity. It was my privilege to be here and represent the nephrology perspective.